So 30-month follow-up data is 88% successful. Now you have 5-year data. And these are the placebo-controlled trials that are now finished. These are the preliminary results, but essentially they didn't change with the subsequent follow-up. And this was done over 3 years, but there was a 1 year of data that they looked at. Basically they cut people, went in, looked at the nerve, right, and then pulled out and closed in the sham surgery folks, and this was double-blinded or triple-blinded, whichever. So, and this showed, interestingly showed 92% improvement in the treatment group with more than half headache-free at 1 year. The shams had 50% improvement, so there definitely is a placebo effect to surgery. There always is. I mean, there's a placebo effect in coronary artery disease, and actually there's a way to quantify which diseases have the highest placebo effects, and migraine's pretty close to cardiac disease apparently in terms of how good a placebo can mimic results. But they had 50% improvement, but none were headache-free, which is, I mean, that's hugely statistically significant. 4 trigger sites, I've beat this into you. So 2 minor sites, I think, anyway. The auriculotemporal nerve, this hasn't really been described, and then the lesser occipital nerve. Then there's also the greater auricular nerve. I mean, all these nerves come out in the brainstem, sort of in the same area. I'm not really sure why one's going to be more, unless it just happens to be enveloped by muscles, like the one in the back of the neck. So certainly there are nerves that are much more likely to be affected if they travel through a muscle versus one that travels between all of them. Migraine threshold, I already presented this, and basically I think that you get enough sites. If you identify a trigger site and you treat it, it's going to increase your threshold. If you get all of your thresholds, I mean, if you get all of the trigger sites deactivated, then your threshold's so high that you can have a hangover like everybody else, and not call it a migraine. But I think it's sometimes, and I don't know if you've seen this, you've lost patients that have had, say, 1 trigger site treated, especially if after it's an injection and they have a bad headache afterwards, and they're like, well, I'm not going back, because they don't realize that there are multiple sites that need to be addressed. So anatomic injection technique, which is really, really important, and we'll go over that with our patient. So the screening process, she already went through all that. These are the 4 surgeries. The endoscopic brow, which can be done with a telescope or can be done through the upper eyelid, and that treats zones 1, these 2 nerves, and then the temple nerve as well. So those 2 zones are usually covered with essentially an aggressive brow lift. The greater occipital nerve decompression in the back of the neck, that's an incision that's all within the hair. It starts at that bump on the back of your head and stops where the hair stops. And then the septoplasty, partial turbinectomy. This is really the only operation that's kind of, you can find it in ancient surgical text. This has been done, brow lifts have been done for a long time. This has been done by plastic surgeons and ENTs for a long time too. And this surgery is very akin to doing carpal tunnel surgery in the back of the neck, is really what it's sort of akin to. Most patients get 2 to 3 sites. This auriculotemporal nerve decompression is the nerve in front of the ear that I was talking about as a minor site, and I think at least one person, couple people in here have had that done. So this is the endoscopic. We're getting close to the pictures. Endoscopic approach, a little incision here, usually 5 little incisions like that, and basically go down and decompress these nerves here. And that's a bad picture of the supraorbital and supratrochlear nerves, which come out as I've shown you. This is a picture using the telescope. This is a little camera coming in. This is the frontal bone here, and this is the periosteum, which is kind of like the skin of the bone that's lifted up, and then a little tiny incision's made in that periosteum right here, and you're seeing probably the supraorbital nerve right there. When dissection's carried out further, you see muscle wrapped, all around this area, which is normal to have muscle around that nerve. It's just not a good thing for migraine patients. Doing the back of the neck, we started doing this here over at Acadia Medical Arts. We're doing this now with the patient awake or very heavily sedated, essentially asleep, and sometimes with video goggles. As one of our patients in here got to watch True Grit while I did that. I remember when he said, I think he spat on the dog. I asked him, I said, what's going on in there? And he said, and you were kind of groggy and said, I think he just spat on the dog. So I haven't seen that movie in decades, but I'll be looking for that. So this is the operating position, and this allows the patient basically just to sort of get into this position. And then from this position, if I'm doing the front, then we just lie the patient back, and then they go to sleep, and we do the front. This is where the hair stops here, so the patient's head is up here. This is the little bump on the back of the head, and then the scalp stops at this point here. It's an incision right in the midline, and then this is the big nerve. It's a pretty big nerve there, and that's like maybe half the size of my pinky, and there's one on either side. And this right here, you can't see very well, but there's a little shadow here. That's muscle that's going right over that nerve, and that's what we remove. This, I don't know if you can see this. This is a picture of mine, and this is a greater occipital nerve. What this is around, this little loop, vessel loop here, is wrapped around, is muscle that's going right between, I mean, splitting the nerve in two, which I've seen now twice, and I think Dr. Gowron and some of the other guys at the conference said that they had seen that. And that was the patient's symptomatic side. So you have this big giant nerve with a big piece of muscle going right through it. Once you clean off the muscle off around the nerve, then we take a little bit of fatty tissue and we wrap it around so we exclude the nerve from muscle fibers. And that's really the principle here. It's a principle in the back of the neck as well. So over the last 4+ years, going on 5, we have seen over 60 patients. We have just 29 surgical patients. Average follow-up of 23 months. Age range is between 10 and 66. I just did someone that was 10 years old, which was, we thought long and hard about it, and it was I think it was the right decision for the kid. He was really, missing school every single week, and had come up from New Hampshire, and I told him I haven't done this on children. I know that we've talked actually about children and migraines at our conference, but I can try the Botox. They injected it for kids that have blepharospasm and other problems, so we inject the Botox, and the kid cried, and then it was about 2.5 months later, his dad called and said, my son's been unbelievable the last 2 months. He's like his old self again. He's, but now he's bad again. He's throwing up at least once a week. He's missing school, and we want the surgery. I don't care what you say. We want the surgery, and my son is begging me to take him back up to Bangor to get another Botox injection. So that's kind of what it took to get me to do the surgery on him, and it's too early to tell, but he initially has been doing well. These patients that we see here and in Cleveland and Dallas and Wichita and and in Georgetown University, I mean, they're all really bad off. They're not just episodic migraine sufferers. They're usually have had no success, or they're just intolerant of the medications and other alternative therapies, and most people have tried all the other stuff, biofeedback and acupuncture and massage therapy. Botox injection technique was a big problem, I think, for me, and I think it evolved over the last several years, changing the dilution and the injection techniques, and I think we've kind of all sort of agreed on what works best right now. So I've treated a total of 77 sites in those patients. So 89% of the patients I've treated have had greater than 60% improvement. 32% have had between 90 and 100% improvement. Most of these folks are off their migraine medications. The average subjective improvement, including the failures, is 79%. The pre-op MIDAS score, which is it's a questionnaire that looks at the number of days you miss from work, the number of days you're less than 50% productive at work, same thing at home, and then the number of leisure days that you've missed because of your headaches. That pre-op MIDAS was 80, and the average post-op MIDAS is 10.6. So we've had 2 recurrences at 1 year. Surgical site issue, numbness, tenderness over the surgical sites, cysts or ingrown hair. I've had a couple of those in the back of the neck, and I think it's because I'm closing the scalp too much like a face, and I should probably use staples because that tends to leave less cysting. Temple hollowing, have one patient with some mild temporal hollowing. Bruising immediately post-op, certainly, and numbness immediately post-op. Takes a while for the sensation to return. Dry nose and a sinus. It wasn't really a sinus infection, but I called it that. But basically no complaints of any of these have registered as a greater than 2 out of 10. So these have been things I've sort of rooted for generally. Most common side effects of the surgery: improved breathing and change in brow appearance. And I'd like to think that most folks feel that it's an improvement in the brow appearance. So, but I can tell you, I haven't had a single patient that I felt was coming to me because they wanted a brow lift. Because that's what everybody thinks, oh yeah, go get your brow lift for your migraine, I mean, these people are, they're generally just miserable. That's the last thing on their mind.